Hi, I'm Jason Porter. I'd like to thank the organizers of the West Cancer Center APP conference for inviting me to discuss non-small cell lung cancer updates with you. So first, what is lung cancer? We know it's cancer that originated in the lungs, but we subclassify it by the histologic subtype. We look at non-small cell lung cancer, which makes up 85% of lung cancers versus small cell lung cancer at about 15%, depending on where you are studying or taking care of your patients. Non-small cell lung cancer is further subdivided into different histologic subtypes, at 40% being adenocarcinoma, or the most common type of lung cancer. Secondly, squamous cell carcinoma, representing about 30% of those patients. And lastly, large cell neuroendocrine at about 15% of those patients. When we look at adenocarcinoma specifically, we break that down, and you can see it on the far right side, into molecular subtypes. So oncogene drivers like EGFR, ROS1, ALK, the MET-exon 14 skipping mutation, as well as KRAS, G12 mini, G12A, B, C, G12C being relevant with an approved therapy. We study adenocarcinoma as well as squamous cell carcinoma to look for oncogenes, and we have to do that because now non-small cell lung cancer is not a diagnosis, neither is adenocarcinoma, but we need to know the molecular derivation or driver for those tumor types, so that when we find patients who have mutations such as EGFR, we know how to treat them. In the early stage, patients who have EGFR mutations are now treated in the adjuvant setting after surgery with an osimertinib or EGFR inhibitor. And that's according to the findings from this trial, ADORA, the phase 3 study that randomized patients to receive osimertinib or placebo 1-to-1 after surgery for 3 years. The patients were being studied to assess disease-free survival. Also, the disease-free survival specifically in the stage 1B to 3A, as well as the 2 to 3A, overall survival, safety, and health-related quality of life. Early in the analysis, we saw a separation of the primary or progression-free survival curves, with the hazard ratio of 0.20, median disease-free survival not being reached for the osimertinib-treated patients versus 27.5 months for patients treated with placebo. Later analysis, as recently as this past January 2023, showed that the hazard ratio was 0.27, with a 73% reduction in progression for patients treated with osimertinib, with a median PFS of 65.8 months on osimertinib and 21.8 months on, or 28.1 months on placebo. In the central nervous system, we can see delayed to central nervous system progression for patients who were treated with osimertinib. The hazard ratio being 0.24, median progression free survival in the CNS not reached for neither the placebo nor the osimertinib treated arms. Stage doesn't matter. For stage 1B, stage 2, and 3A, we saw an improvement in the survival for those patients, or at least a trend towards improvement in survival for these patients. And I think that we need further analysis and further follow-up, even though technically we've reached 5 years of follow-up for this particular clinical trial. We can see that the patients who are treated with osimertinib still 94, 85, and 85% still alive at 5 years. We look at overall survival based on whether or not the patients received adjuvant chemotherapy before going on osimertinib. We know some patients can't tolerate chemotherapy, so this is a very important question that needed to be answered. And honestly, we don't see a big difference for patients who receive chemotherapy, then osimertinib, or who just go right on to adjuvant osimertinib without receiving chemotherapy. The median overall survival for those patients without chemotherapy, 88 versus 79%. Osimertinib versus placebo, and with chemotherapy, 87 versus 77%, osimertinib versus placebo. So in conclusion, ADORA is the first phase 3 trial to confirm improvement in overall survival for patients in the adjuvant setting who receive an EGFR inhibitor, particularly osimertinib. We saw improvement in the primary population's overall survival, as well as the overall survival for stage 1B to 3A, with a hazard ratio of 0.49 for both of those patient populations. And indeed, an improvement in CNS relapse for those patients who were treated with osimertinib. And this is the standard of care in the adjuvant setting for patients who have EGFR mutations. If they do progress and become metastatic, or if they were metastatic at the time of diagnosis with an EGFR positive or mutated non-small cell lung cancer, and then they progress on osimertinib, what do we do next? So after an EGFR inhibitor, the patients from Keynote 789 were randomized to receive pembrolizumab plus platinum doublet chemotherapy, or placebo plus platinum doublet chemotherapy. These patients were being assessed for dual primary endpoints of progression-free survival and overall survival, and secondary endpoints of the response rate, the duration of response, response, and then also safety and patient-reported outcomes. They were randomized if they had common EGFR mutations, in other words, deletion in exon 19 or L858R mutations in exon 21. Rare mutations in EGFR were not included. After first or second generation EGFR TKIs or after receiving osimertinib, they could go on. They were stratified by their PD-L1 level, their treatment history, as well as their geographic region. At interim analysis 2, we saw a statistically significant improvement in progression-free survival. We can see here that has a ratio of 0.8 with a median PFS of 5.6 versus 5.5 months. So there's a trend towards improvement in PFS, but at the overall survival analysis, statistical significance was not met. So we can see it has a ratio of 0.84 with a median overall survival of 15.9 months for patients who received pembro plus chemotherapy versus 14.7 months for the patients who received placebo plus chemotherapy. In conclusion, pembrolizumab, when added to platinum doublet chemotherapy for patients with EGFR mutations who progress on their EGFR inhibitor, did tend towards improvement in survival, both progression-free survival and overall survival for patients with EGFR mutations, but there's not a statistically significant improvement in overall survival, and the benefit seems to be minimal, and we know these patients with EGFR inhibitors can have meta-amplifications as well as other mechanisms of resistance, and at that time, we should study those patients to look for a mechanism of resistance that we can continue to target. For earlier stage patients who have non-small cell lung cancer, who are able to have surgical resection of their disease, we see CheckMate 816, where nivolumab plus chemotherapy versus chemotherapy alone improved outcomes for patients who had early stage disease when they were randomized 1-to-1 to those patient arms. So patients with newly diagnosed stage 1B, greater than or equal to 4 centimeters, to 3A non-small cell lung cancer with good performance status and no oncogene driver like EGFR ALK were randomized to those arms. And then within 6 weeks, they had radiologic restaging and went on to surgery, followed by adjuvant chemotherapy and or radiation if indicated, where we were looking for endpoints of pathologic complete response and event-free survival in these patients, secondary endpoints being overall survival and time to distant metastasis, and an exploratory analysis of outcomes in patients by definitive surgery status, or whether or not they were able to get that definitive surgery. Event-free survival by definitive surgery status is shown here. And for patients with definitive surgery, we can see a median EFS of not reached versus 31.8 months for patients, statistically significant. And also without definitive surgery, still an improvement or trend towards improvement in the outcomes or EFS for those patients with a median of 6.7 versus 4.1 months. For the time to distant metastasis for patients who were able to undergo definitive surgery, we see a median time to distant metastasis not reached for patients who received nivolumab plus chemotherapy versus 46.8 months for those patients who received chemotherapy alone. Without definitive surgery, we still see an improvement in the time to distant metastasis, and it is not statistically significant, but it trends that way. The 24.8 months for nivo plus chemo versus 15.6 months for patients who received chemotherapy alone. EFS2, by definitive surgery status, we can see here with a median of not reached versus not reach in the chemotherapy versus nivo plus chemo arms for those patients with definitive surgery. Without definitive surgery, we can see a median of 12.3 months for EFS2 versus 15.5 months for patients receiving chemo. Neither of these were statistically significant. And there's no difference in outcome or EFS2 based on the definitive surgery status. But what therapy did those patients receive if they did not go on to receive definitive surgery? We can see chemotherapy, we can see radiotherapy for many of those patients. We can also see chemo and immune therapy combinations for those patients, as would be expected for a patient without an oncogene-driven tumor. So in CheckMate 816, we see improvement in the EFS, the time to distant metastasis, and the EFS2 for patients who had definitive surgery. For patients who were not able to undergo definitive surgery, there's a trend towards improvement in those outcomes, but it's not statistically significant. The addition of nivo to neoadjuvant chemo did not increase the incidence of severe adverse events, and we know that this regimen is tolerable. We use it in a metastatic setting or similar regimens in the metastatic setting, and these do confirm that CheckMate 816 continues to be an authorized and approved option for neoadjuvant therapy for patients who have early stage non-small cell lung cancer able to undergo definitive resection. Keynote 671 is another early stage clinical trial in non-small cell lung cancer. This is looking at perioperative pembrolizumab plus platinum doublet chemotherapy for patients who are able to undergo resection of their non-small cell lung cancer. So the trial looks like this: pathologically confirmed stage 2, 3A, or 3B, according to AJCC version 8, who had no prior therapy and were able to undergo surgery with a good performance status, were randomized 1-to-1 to pembro plus chemo versus placebo plus platinum-based chemo for both of these groups. Then they went on to surgery and followed by maintenance pembrolizumab or placebo, with the dual primary endpoints of investigator-assessed event-free survival, as well as overall survival, and key secondary endpoints being major pathologic response, pathologic complete response by blinded independent central review, and safety. We can see here that has a ratio of 0.73, clinically statistically significant or trending towards for patients' overall survival who were treated with perioperative pembrolizumab plus chemotherapy versus placebo plus chemotherapy. Percent patients with events was 19.1 months or 19.1% with the pembrolizumab arm and 25.3% with the placebo arm. Pathologic complete response assessment here, we can see the major pathologic response rate of about 30% for patients who were treated with the pembro versus 11% in patients treated with chemotherapy alone, and a complete pathologic response or pathologic complete response of 18.1% for patients with pembro versus 4% for patients with chemotherapy alone. So neoadjuvant or perioperative pembrolizumab has shown to be clinically beneficial for patients who are able to undergo resection of their disease for non-small cell lung cancer, and is now an option for care in those patients. We await FDA approval for this approach. Small cell lung cancer can be subclassified, which we have not routinely done. And now that we're starting to do that in clinical practice, we don't see the application yet, but we expect to see that come. And we know that non-small cell lung cancer is many various diseases, like we showed at the beginning of the presentation. The same thing is true of small cells. So we see the ASCL1 subtype, the NeuroD1, and the PU2F3 subtype, or small cell lung cancer, A, N, P, and I, another way of classifying the small cell lung cancer. So right now, the approach used in small cell lung cancer is an immune checkpoint inhibitor plus platinum doublet chemotherapy, namely durvalumab with platinum and etoposide for those patients in the Caspian study. And then for patients in the Empower 133 study, that's atezolizumab plus platinum doublet chemotherapy. Both clinical trials randomized patients to receive the platinum doublet with or without the immune checkpoint inhibitor. And when we look at the primary toxicity seen when treating these patients in the early stage, myelosuppression is one of the toxicities of interest. We suppress the bone marrow by using a platinum doublet chemotherapy. The addition of the immune checkpoint inhibitor does not really change the myelosuppression or the myelotoxicity that we see with the regimen. It's mostly from the platinum doublet chemotherapy. The reason is we suppress hematopoietic stem cells in the bone marrow, and we need to figure out a way to save those bone marrows or spare them toxicity. So trilaciclib, in addition to platinum and etoposide, with or without that atezolizumab from the Empower 133 trial that we looked at earlier, here is the trilaciclib clinical trial. And in that trial, those patients were given on day 1, platinum plus etoposide plus their trilaciclib, and then on days 1 through 3, or in days 2 and 3, continued etoposide plus trilaciclib. We were looking to improve severe neutropenia, and then also supportive care indicators like the use of GCSF, the need for red blood cell transfusion and platelet transfusions, as well as the need for ESA, or erythropoietin stimulating agents. When we added trilaciclib to those therapies, we did improve upon those metrics. We see an improvement in the duration of severe neutropenia or chemotherapy-induced myelosuppression when we use trilaciclib versus not using. And then the decrease in red blood cell transfusion, the decrease in the percentage of patients with grade 3-4 anemia, also decrease in the need for platelet transfusion, as well as grade 3-4 thrombocytopenia. After progression on atezolizumab or durvalumab plus platinum doublet, which is the standard of care according to Caspian and the Empower 133 trials that we saw, we can see here lurbinectedin as a second-line agent. And from a single-arm open-label phase 2 basket trial, the overall response rate was about 35%, 35.2% for patients treated with lurbinectedin. Many of these patients had received chemotherapy within 90 days, but several of them, most of them, had not had chemotherapy within 90 days. And now we know that there's data that shows that greater than 90 or greater than 60 days, greater than 90 days or greater than 6 months from the last chemotherapy does improve response to lurbinectedin as well as the duration of response to that therapy. Now that we're starting to subtype small cell, can we use targeted therapies in small cell? Tarlatamab is a bispecific T-cell engager therapy that's directed at DLL3 or delta-like ligand 3 on these small cells, which is expressed in about 85% of those cells. So the use of tarlatamab in this early clinical trial showed response across patients who have been heavily pretreated with small cell lung cancer. And we know right now in second line, we get minimal response. We just saw only 35%. So is there a way to improve upon that for those patients? So in this phase 3 open label randomized trial of tarlatamab for patients who had already progressed on standard of care, which would be platinum-based chemotherapy, they were randomized 1-to-1 to receive tarlatamab as an infusion versus topotecan, lurbinectedin, or amrubicin, depending on what region of the world you were in, specifically amrubicin for Japan. The primary endpoint was overall survival, key secondary endpoints, PFS, and patient-reported outcomes. And so in the phase 1 study, of tarlatamab, we did see manageable safety. And it's encouraging to see the responses that we saw on the previous slide. And so now there's a DEL-5 304 randomized open-label phase 3 trial of tarlatamab compared with standard of care in about 700 patients with relapsed small cell lung cancer after platinum-based therapy. And we're looking for responses, and hopefully we'll be able to bring a targeted therapy to small cell with tarlatamab. S1929 is a phase 2 study of atezolizumab versus atezo plus talazoparib for patients who have Schlafen-11 positive small cell lung cancer. So these patients who have received their initial standard of care therapy with platinum doublet and an immune checkpoint inhibitor will then randomize to receive in arm A atezolizumab alone or in arm B atezolizumab plus talazoparib if they had Schlafen-11 mutations. Okay, remember that Schlafen-11. Primary endpoint being progression-free survival, secondary endpoints overall survival response rate, as well as AEs. And so we're looking at safety for those patients. The progression-free survival is shown here. The curves really don't look all that different, but if you look at the numbers, the median in months of 2.8 months versus 4.2 months is what we found. And this technically was clinically statistically significant. So we can target patients who have Schlafen-11 by adding talazoparib to their atezolizumab maintenance with small cell lung cancer. And we look at the preliminary overall survival. Again, it's preliminary, it's premature, and so it's still got some growing to do, but we can see already a technical separation in the median overall survival for those patients at 8.5 versus 9.4 months, but again, has not reached statistical significance yet, but studies are ongoing. For ifinatamab deruxtecan, we can see another targeted approach to small cell lung cancer for these patients who have progressed on their initial therapy. They were given a B7H3 targeted therapy that brings deruxtecan as a payload to cells expressing B7H3, specifically small cells. And we were looking at the payload mechanism of action, the high potency of the payload, the optimized drug to antibody ratio being 4, and then also the payload with short systemic half-life. And looking at this molecule, we see that in a dose adjustment that we reach a dose of about 12 milligrams per kilogram, and then we go on to expand those patients in the ongoing clinical trial, and we have primary endpoints of the dose escalation. With primary endpoints of response rate, duration of response, disease control rate, and progression-free survival, as well as overall survival. The early analysis with ifinatamab deruxtecan or IDXD against B7H3 shows improvement with a response rate of 52% for these patients who had relapsed on earlier stage treatment, heavily pretreated small cell lung cancer patients, which is unprecedented at 52%. Remember, we saw in second line with lurbinectedin only about a 35% response rate. Is well tolerated with no new or concerning safety signals. This antibody drug conjugate has ongoing studies of phase 2 for patients with extensive stage small cell lung cancer after 1 to 3 lines of therapy is ongoing, and we should continue to follow those. So in conclusion, osimertinib improved adjuvant outcomes for patients after surgery. If they received 3 years of osimertinib, we saw improvement in the progression-free survival, the overall survival, intracranial survival, or progression-free survival for those patients. Upon progression, we know that those patients who have EGFR mutations or metastatic disease need to have a determined mechanism of resistance whenever possible so that we can keep them on targeted therapy. Neoadjuvant nivolumab with chemotherapy improves the event-free survival, time to distant metastasis, EFS2 without added toxicity, particularly for those patients who are able to go on to have their definitive therapy or surgery. Perioperative pembro plus chemo has improved EFS, and overall survival data continues to mature. Lurbinectedin after durvalumab and atezolizumab, which are the current standard of care for extensive-stage small cell lung cancer, has good response rates, particularly for patients who have been off chemotherapy for greater than 90 or 60 days. We can protect the bone marrow with trilaciclib and hopefully keep those patients on small cell-directed therapy, on their therapy and on time. But in the time of starting to subclassify small cell lung cancer, approaches like tarlatamab and infinatamab deruxtecan are ways that we can actually target small cells, as well as atezolizumab plus talazoparib maintenance for patients who are SLOPN11 positive. So that's it for updates in non-small cell lung cancer, as well as small cell lung cancer for this APP conference. Again, I thank you for allowing me to participate, and we look forward to hopefully doing this again in the future. Have a great day.